Good morning. I'm going to do it slightly differently in terms of presenting this topic of ischemia. Now, what I've done is I've endorsed the Slido tool with questions for the audience, so it's important that you log on and try to answer some of the questions later on. The first set of slides are very much based around just a few kind of ideas on the advancements of echocardiography. So these are images which are demonstrating anatomy. Clearly, when you look at these, they are very detailed images. And what makes this special? It's quite amazing the amount of time and effort that has gone into these images demonstrated many, many years ago. How does this impact on some of the work that we go on? It goes on to detailed images of the heart, which were done by Leonardo da Vinci almost 500 years ago. Now, these, if you look very carefully, you can see very, very detailed images of the coronary tree, which wraps around the myocardium there. In fact, some of the literature there that is written there, so if you look at some of the literature there here, it's actually a mirror image of exactly what it means. So if you put a mirror, you can actually read it better. But certainly, this kind of links some to the ischemia that we're going to be looking at. But a brief introduction on to who I am. My name is Waheed Akhtar. I'm a consultant in echocardiography based at the Lincolnshire Heart Centre, where we have almost a very active department where we are focused on performing an advancement of echocardiography with education attached to it. I've been involved with echocardiography for almost 25 years, actively involved with the BSE as well. So the Lincolnshire Heart Centre, like any echo department, has a dedicated stress echo lab, which is a setup over 3 sites at Lincoln, Grantham and Boston. Now, these are actually represented by, not just by me demonstrating what we have here, it's also, part of the team, the expert physiologists that we have amongst the expert consultants that lead. We perform over 750 cases, and our percentage load is actually listed here. And if you look very carefully, about 70% of it is ischemic heart disease. So this is some of the advancement of 3D echocardiography. Well, what you're seeing is two-dimensional imaging of stress echo. Now, if you look very carefully, you can see a 4-chamber demonstrating there. But when you look at this 4-chamber, the apical region is slightly kind of demonstrating a defect. Now, 3D plays an important role. Certainly, I endorse it as much as possible. And how do I do that? I look at some of the 3D contrast 9-slice cropping and try to crop right to the apex of the heart using the dynamic heart model. This is actually very useful and allows you to demonstrate and look right into the apex of the heart. Again, trying to demonstrate it again here. So if you look very carefully, you can see all the right to the apex, to the base, and you can clearly see it's a normal response. You can do it without contrast as well. So without contrast, again, it's much, much clearer. Certainly 3D imaging is beautifully demonstrating there, so you can be very confident in demonstrating ischemia. So in fact, these images were done 2007, so you can see how much we might have progressed. In the same way, we can look at viability using three-dimensional. So this is something that I endorse constantly. And I think it's important we kind of utilize these tools to demonstrate what we're looking at and gives us more confidence. Also, the next aspect, this is actually myocardial perfusion imaging, which again, we utilize that sometimes. And again, it's at the research level. But the key thing for this is that showing perfusion. If you look at this, you can see a flash which takes place here. Here it goes. So just wait, there it is. So you can see perfusion taking place beautifully. So we know perfusion does take place when you utilize this type of technique. So now let's just look at it in terms of how we utilize that in our own system. So this is the normal demonstration of a normal study, essentially. But again, we'll show how this can be incorporated within our system. So these are the baseline images. You've got baseline, low dose, followed by peak images and peak recovery. Again, normal response there. Just go on to the next image. So here I like to take 3 images together just to really demonstrate if there is any type of ischemia or not. But when we go on to the next couple of images, we can see how this can be incorporated. So it might not project very well, but if you look very carefully, you'll be able to see. So flash will occur in a moment. So this flash replenishment is a very useful tool for looking for ischemia. So it's probably more prominent on that image. So now we're going to go into the cases. So the first one is a nice straightforward case. A male 52-year-old who's a renal patient. So from our kind of caseload, 10% of the patients are renal patients. Hypertensive, renal workup. I do apologize. So male 52-year-old renal patient, it's a worker for renal transplant. The baseline ECG was done. That was essentially sinus. Baseline echo is performed on nearly all patients that we perform stress echo. Again, that demonstrated essentially a normal LV function with no regional wall motion at rest. Good views, so contrast is not used. So the dobutamine stress echo is performed on this patient with a standard 4x4 template, followed by a 4-stage dobutamine protocol, which is standard plus or minus atropine. So these are the images. So this is what we do normally, so standard images. So you can see how beautiful these images are, and it is important that we take time and demonstrate those images nicely. So again, a good response. So these are baseline images. Going down to the peak images, you can see the heart rate taking it up to about 144. So essentially a normal response there. There's a 2-chamber, apical 2-chamber. That's not playing, so there's apical 3-chamber again. And short axis, there's also a 5th view that we also do. And sometimes you can utilize speckle tracking as well, just to demonstrate and give us more confidence to see if the overall function is essentially normal. So the results of this demonstrated that target heart rate was achieved, good level of stress was achieved, no evidence of ischemia, patient had no chest pain, demonstrated with no symptoms. Normal ECG at rest and peak, essentially a normal study. So going to case 2, 63-year-old male, ongoing chest pain, very short of breath on exercise, had a recent MI. When we look at the angiogram, in a moment I'll show the angiogram, it showed RCA disease, moderate disease. The consultant carried out a pressure wire study, which was negative. Ex-smoker, so family history as listed there, he's got some coronary heart disease. And they suggested that they wanted to do a target study to just focus on the inferior territory. So this is the angiogram. So you can see a lesion there. And essentially there is some disease there as well, but certainly that's what the area of interest was the inferior territory. So when we look at that, for this patient, a baseline scan was performed, not very good imaging, so therefore we thought we'll use contrast because it is important that if you see segments not seen, certainly if you look at very carefully, not seen there, the posterior is not seen again, and also the apex and the anterior region is dropping out there. So it's important to use contrast. So we go on to use contrast for these patients. Now the patient itself is consented for the procedure. 4-stage dobutamine protocol is set up. Maximum 40 mics was given for this patient with 450 mics of atropine. Target heart rate was achieved by 151 beats per minute. Essentially normal BP response. So this was the stress. So if you look very carefully, again, a normal response there, normal response there. Let's go on to the inferior one, slightly down there, suggesting there was some impairment. Again, normal response there, maybe slight improvement there. Certainly inferior territory is a lot better. And it continues to improve. So infralateral territory is pretty good as well there. So again, I'm just demonstrating focusing on the inferior territory there again. So if you look very carefully, you can see good kind of viability in that territory. The ECG showed some changes there. but not that significant. So the results were essentially no evidence of ischemia demonstrated in any territories, some evidence of viability demonstrated, and is referred back to the MDT meeting for further decision. Case 3 is very interesting. It addresses an important message. A 75-year-old male who has long-standing chest pain, exertional on exercise, radiating down both arms. It normally describes it as being 7 out of 10. He constantly uses GTN spray. He's referred for a procedure. He has got a history which suggests that he's had an MI in the past, and he's on the medication that that's indicated. This is actually very important. There is indication that this patient has had an allergic reaction, so we have to be very, very cautious on whether we use contrast or not for this patient. So the patient was seen back in March of this year, performed a stress echo. So again, the baseline image is demonstrating 4-chamber, 2-chamber, but if you look very carefully, all the walls look good. I think everything looks good in terms of the way it is coming in. So inferior wall, infralateral wall is good. And again, everything looks good there, so quite happy there. And a 5th view is taken just to reassure, because we weren't using contrast. So this part is going to drop off to the questions for the audience. Slide out. So positive study, ischemia in LAD territory, positive study, ischemia in RCA territory, normal DSC study, no evidence of ischemia. There's a biphasic response. So okay, results are coming through. Okay. So we've got normal, that's correct. I think going on to patient is discharged. However, over the next few months, patient continues to develop chest pain, continues to develop symptoms which the patient is using GTN spray more and more frequently. Patient is reviewed back at our Echo MDT meeting where we discussed at length, and the question was, what do we do next? So, question for the audience again. Do we repeat the DSC? Do we perform a CT angiogram, perform an MPI, or do we perform an angiogram? Can't make your mind up there, so there's a choice between yeah or no. So you're looking at, well, in fact, we actually repeated the DSC. So the question is that we go on to this patient, we consented for the procedure, and in October of last year, we, again, could not use contrast, but I just wanted to demonstrate it again, whether we were missing something. So 3-stage protocol was done, only 30 mics of dipytamine, and a target heart rate of 134 was achieved this time. There's a flattened BP response. ECG essentially was sinus. So let's have a look at the angio. So again, if you look very carefully, slightly different in terms of setting, but again, trying to improve these images, but again, it's very difficult. So going on to, so apical 2-chamber again, so if you look very carefully, there might be something here. So it's apical 3-chamber. And again, just focusing on the territory of interest, maybe there might be something in the inferior territory. Of the ECG at peak, so patient ended up having a lot of chest pain, almost 7 out of 10 chest pain. There was good going ECG changes seen in infralateral territory. So the question for the audience, is this a normal DSE study, or no evidence of ischemia, or is this a positive DSE study? At least two vessel disease, positive DSE study with inducible ischemia, RCA territory, or inconclusive study? And excellent. So you've gone for the positive DSE study with ischemia and RCA territory. That would be correct. I think a lot of people would have gone for that. But let's have a look at part B to this. So patient is recovered. Do we discharge this patient? Do we do nothing? Rebook it for an MPI, or do we do an urgent angiogram? Sorry. So again, urgent angiogram is correct. So we'll go on to the angiogram here now. So you can see complex disease here. That's almost a CTO in one territory. Inferior is not that bad. So where we saw ischemia in the inferior territory, sometimes it's not always the case. You might demonstrate ischemia in one territory, but it can also reflect a disease in other territories as well. So the patient went on to have a complex procedure, and we got good flow there. So a successful procedure overall. Patient was seen 4 months in clinic. Patient now feels a lot better. Medically treated and discharged, but final thoughts, most important things. The first stress echo that was performed in March, the target heart rate was not achieved really. When you look at it, it was only achieving about 114. No ECG was demonstrated. So second stress echo, we pushed the heart rate to almost 10% above the target heart rate. Contrast was not used, but again, that would have improved. But certainly the key thing is that pushing that kind of procedure, achieving our target heart rate slightly above always helps. So case 4, going on to, which is a very old case, was done back in 2007. Now, this is a young female, 47-year-old, long history going back to 1999. Shortness of breath and exertion, and she was labeled as having an impossible angina back in 2006. A lot of DNAs occurred from that time. Eventually attended our kind of coronary care unit, where she was demonstrating having nocturnal chest pain. ECG showed signs of bradycardia. Family history, there was several risk factors attached to it. Patient was again treated and discharged. An exercise test was booked for the patient in 2006. She achieved 6.5 minutes of exercise, shortness of breath. There were some changes, ECG changes demonstrated, anterolateral ST depression. Test was ended, and it was referred for a stress echo. Again, the standard procedure is done where patient is explained, consented for the procedure. Contrast is used for this procedure. Again, 4-stage setup, 600 mics of atropine was used. The target heart rate was achieved at around about 140 to 150. BP responded with normal with exercise. Patient did demonstrate severe chest pain. ECG showed ST changes in recovery after 2 minutes, and beta blocker was given to relieve the pain. So let's have a look at the images now, okay? So this is baseline images, slightly done differently back in 2006, but certainly the same kind of demonstration. So again, looks good there. So going on to our next set of images, which are the low dose. So something is being demonstrated maybe in the, sorry, I do apologize, it's not working there. So let's just see for the next images. So again, if you look very carefully, there might be something here in the inferior territory, just not a normal response. So the question for the audience, is this LED ischemia? Is it RCA ischemia, circumflex ischemia, or normal DSC? Yeah, I think, yeah, clearly RCA ischemia was demonstrated. But let's have a look at the angiogram. Patient, went on to have an emergency angiogram. because it was crucial with the changes. Now, this is actually quite alarming when you see this. So it's actually demonstrating normal coronary for the arteries, but the right coronary essentially is normal with severe ostial spasm with ECG changes. So nitrates were given, and diagnosis was put down as coronary spasm. Patient was discharged. So that's an important finding for this patient. So with history going back since 1999, the patient himself was labeled of having variant angina. But the most important thing is that sometimes with debutamine, can we create that ischemia? Maybe this case actually demonstrates that. And also the fact that the patient actually now, moving on with time, I'm sure is a lot better. So case 5. So again, this is a complex case. Patient, 73-year-old male. Main thing is that there's not much cardiac history for this patient. He's got quite a lot of other history. He's on a whole range of medication. Risk factors, ex-smoker, drinks alcohol, no family history. He has typical chest pain and shortness of breath on exertion, and is referred for an extra DSC. So these were the baseline images of the transthoracic echo. Again, the images weren't very good, so contrast was going to be used. So this is the contrast being used. So again, if you look very carefully, this is the apical 4-chamber at baseline, low dose, and peak. There's something demonstrating in the apex here. Again, clearly seen something abnormal going on there. Also seen in the 2-chamber view. So clearly there is something not right there for this patient. So let's go on to the 3-chamber view. And again, that is definitely seen. So we see multiple views. We are seeing changes there. So we're going on to the short axis view there. So target heart rate was achieved for this patient. 40 mics of debutamine was given, followed by 300 mics of atropine. Patient had chest pain, significant chest pain, almost 7 out of 10. Chest pain subsided quickly into recovery. SD changes seen on ECG. And GTN spray was given to relieve the pain. But the key thing for when the patient was referred, there was no history. So patient goes on to the question. So is this a normal DSC study, positive DSC study with RCA disease, LAD ischemia, or circumflex ischemia? So yeah, I think clearly we can see the apex was going, so LAD disease there. So let's have a look at the angiogram. So angiogram was performed for this patient. Some disease there in inferior. Oh, let's go back. Should play. So there it is. So you've got clearly quite a significant amount of complex disease for this patient, considering they were labeled as having no cardiac history. So this patient was referred back to the MDT and was referred for a cabbage rather than a surgical decision for angioplasty. Stop. So case 6. Case 6 itself, again, an interesting case here. 72-year-old female. Patient presented with a history of shortness of breath on exercise, 2 episodes of chest pain, past history, medical history, again, asthma, some respiratory problem there. Patient had no known allergies, discussed with the consultants for a DSE to be performed. The baseline scan was performed, had moderate LV dysfunction, mild to moderate mitral regurgitation, and abnormal resting ECG. Let's have a look at the images now. So this is the 4-chamber. Clearly you can see something going on in the apex of the heart here, there. There's a 2-chamber now, going on to the 2-chamber. Again, clearly there is something not right there in the apex of the heart. So let's just demonstrate it on. I like doing this. This is actually very useful, looking at target lesions. Again, clearly seeing something there. So a question for the audience. RCA circumflex ischemia, LAD ischemia, ischemia in all 3 territories, or normal DSE study. Yeah, so LAD, from what we've seen, I would have definitely put down LAD ischemia, but we went on to do the angiogram. This demonstrated something different. So when we look at the angiogram, normal right coronary, normal left coronary. So it's quite interesting when you see this, you think, what is going on? Now, this was related to possibly a case where Takotsubo cardiomyopathy can be demonstrated on stress. With further decisions, I actually decided to push this patient on to have a CMR. So it's an interesting case. Now, to summarize, ischemia assessment is very complex. It's not easy. You should utilize all the tools. You should utilize all the tools as demonstrated in case 5. It is important that you take your time demonstrating the images, maintain a very high level of quality in terms of obtaining the images. With the extensive training of the physiologist and the consultant, it can be achieved, especially with the modern technology. The correct approach, achieving a good level of stress, is important. This was alleviated and demonstrated on case 3. Contrast should be used in as many cases as possible. And again, contrast itself is a little bit more relaxed in how we use that, and this has been raised many times that contrast is being more and more used. 3-dimensional imaging and also myocardial perfusion imaging can add extra towards the kind of quantitative assessment, and also the correct selection of the patient is needed. So, finishing off this is my daughter here, who's actually holding a transthoracic probe. Lou, just kind of reflecting back to the first slide, and is saying almost what makes it special. She actually told me that it's almost holding like a paintbrush, and it made me think maybe she's right. Maybe Leonardo was right as well. Thank you.